It's a great pleasure to be here, and I'm grateful to Dr. Dhiman and Dr. Goyal for giving me this opportunity. I've been asked to speak on muscle-liver axis. This is the brief outline of my talk. I'll begin by showing you what kind of axis we are going to talk about. Then I'll talk about the conventional paradigm that cirrhosis leads to sarcopenia, and sarcopenia in turn increases the adverse outcomes of cirrhosis. Then we come to more recent data that sarcopenia actually may be causing cirrhosis. And what are the therapeutic applications? And finally, we conclude the talk to give you the big picture. Now, the word axis in biology is generally used to show the control of endocrine organs. For example, hypothalamic pituitary adrenal axis. But the liver axis is something different. It is something like two friends. The liver and muscle are interdependent. And it is very well known that in cirrhosis, sarcopenia develops. And once the sarcopenia develops, the outcomes of cirrhosis are highly adverse. Most of us look at muscles only as an organ of locomotion. What we don't realize is that it is central to our protein metabolism and works as a reservoir of amino acids. During the postprandial state, the glucose is converted into the amino acids, and in the fasting state, these amino acids are converted back to glucose to be utilized by the liver. You have already listened to a brief introduction to sarcopenia from Dr. Sunil Taneja. I will just mention that this term originally came from elderly, and generally we must realize that all of us are losing our muscles 1% per year up to the 70 years of age, and then about 1.5% every year. In cirrhosis, which is a secondary sarcopenia, the rate is more than 2 to 3 times of this. Losses greater than 3% lead to increased risk of mortality unrelated to the severity of liver disease. So far, the sarcopenia was defined mainly as loss of muscle mass, and this point has also been made by Dr. Sunil Taneja, that now we diagnose in 3 steps. First step is to suspect it by a dynamometer, and second step is to look at the structure of the muscle and measure its volume, and the third step is to measure its performance. Initial step suspects sarcopenia, second step confirms the diagnosis, and third step tells you that it is severe sarcopenia. Sarcopenia is defined usually by specific cutoffs, and whatever cutoffs are used, depending on that, the prevalence in cirrhosis is about 65 to 90%. It is also very well known that as we move from child A to child C, the prevalence of sarcopenia keeps increasing. There is a different type of sarcopenia in some patients, which is called myosteatosis. So here, instead of losing muscle mass, your muscle is replaced by fat. It is more common in than sarcopenia in early stages of cirrhosis, especially in obese people, but has similar implications. Muscle mass is determined by anabolism and catabolism balance. And main anabolic factors which are known to increase the muscle mass are protein-rich diet, exercise, testosterone, and growth hormone, and they work through mTORC1. Catabolism, there are mainly 2 pathways, UPP and AP pathways. And in cirrhosis, the main problem is high levels of circulating endotoxins and ammonia, which transcriptionally upregulate myostatin. And myostatin leads to reduction in anabolism and increase in catabolism, leading to sarcopenia. Now, sarcopenia is a harbinger of adverse outcomes. An independent predictor of adverse clinical outcomes in cirrhosis. It causes increased incidence of hepatic encephalopathy, longer hospital stay, waitlist mortality, higher frequency of infections following liver transplantation, increased healthcare cost, post-liver transplant mortality, higher cardiovascular mortality. And because of this effect of sarcopenia on the outcome, it seems that the model for end-stage liver disease, which we usually use like MELD, may under-prioritize these patients for selection for liver transplantation. Now, I'll probably flash very quickly some slides to show you the effect of sarcopenia on the outcomes in cirrhosis. For example, this is Montano Loza's paper, which shows both in cirrhosis and hepatocellular carcinoma, if sarcopenia is present, the mortality is very high. This is Stentai's meta-analysis, which again shows the same thing, multivariate analysis showing association between sarcopenia and the risk of mortality. This is a study from 5 North American transplant centers where the sarcopenia was diagnosed on CT scan, skeletal muscle index, and it showed very clearly that both in males and females, the sarcopenia was associated with high waitlist mortality in patients who were waiting for liver transplantation. This is Punita Tandon's paper, which showed very interesting point that the impact of sarcopenia is highest on mortality if the MELD score is less than 15. If the MELD score is higher than 15, the impact is not so much. This is the presence of sarcopenia can predict presence of minimal hepatic encephalopathy. Most people believe that the effect is binary. That is, the effect of sarcopenia on outcome is binary. It is not really so. For example, this patient, this study carried out in 163 transplant recipients showed that if the muscle mass keeps decreasing, the mortality keeps rising exponentially. And if the muscle mass is good, the mortality is hardly any in these patients. This is the point I was making, that most of the studies which have been published have looked at whether sarcopenia was present or not. But the quantitative assessment has shown that each kg increase in hand grip strength correlated with 6% reduction in mortality, and 1 unit reduction in height adjusted psoas muscle diameter was associated with 15% increase in mortality risk. So it has been suggested that presence of sarcopenia, we should try to add 10 MELD points, at least for those patients who have a MELD score less than 15. Myostatin also has similar effect. The number of studies are less, but it has been shown to decrease the muscle function, muscle strength, decrease mobility, performance, impaired longevity, increase insulin resistance, type 2 diabetes, and also increased risk of hepatocellular carcinoma. High mortality caused by sarcopenia has no relationship to MELD. While the prevalence of sarcopenia is related to the liver function, that is, worse the liver function, higher is sarcopenia, but the impact of sarcopenia on mortality is not related to MELD score. This is possibly best shown in people who have lower MELD scores less than 15. Now I move to the more recent knowledge. The recent paradigm is that sarcopenia may be leading to increased risk of NAFLD and liver fibrosis. This is the Korean sarcopenia obesity study, which has clearly shown that sarcopenia correlates with higher prevalence of NAFLD among obese people. This is the Belgian study that has shown that myosteatosis is strongly and independently associated with liver stiffness in obese patients with NAFLD. They raise the hypothesis that myosteatosis contributes significantly to progression of liver fibrosis. This is another study where patients with metabolic liver disease with chronic hepatitis B were studied, and similar results were shown in such patients also. Patients with these patients showed, or those with sarcopenia had greater risk of liver fibrosis. Here again, it has been shown, this is an Italian study which gave the same message, that sarcopenia was associated with severe liver fibrosis in patients with NAFLD. And this meta-analysis has confirmed that sarcopenia not only increases the risk of NAFLD, but also increases the risk of liver fibrosis. Thus, a causal relationship is now being suggested Sarcopenia leads to insulin resistance and chronic inflammatory state, which in turn promotes development of NAFLD as well as fibrosis in these patients. Once the cirrhosis is developed, it further aggravates sarcopenia, thus setting up a vicious cycle. While the evidence for such a vicious cycle does exist for NASH-related chronic liver disease, its extrapolation for other modalities is currently a matter of conjecture. What therapeutic implications can we have? Can we break this vicious cycle? Both cirrhosis as well as sarcopenia are potentially curable diseases. But what is the impact of this cure? The impact of liver transplantation and curing liver fibrosis on sarcopenia has not been studied very well, nor the reverse has been studied, that if the sarcopenia can be treated, what happens to the liver fibrosis or liver condition is not clearly known. So this is a good point for you. If you want to carry out research, these are gaps in knowledge, and you can pick up research projects on this issue. So I'll summarize by saying that sarcopenia is common in cirrhosis and seriously affects clinical outcomes. Outcomes are linearly related to the loss of muscle mass. Sarcopenia increases the risk of non-alcoholic fatty liver disease and fibrosis progression in non-alcoholic fatty liver disease. Sarcopenia is more common in later stages of cirrhosis, but its impact on outcome does not run parallel to MELD score or liver dysfunction. The role of sarcopenia in early stages of liver disease progression appears much greater than in later decompensated stages. We will do well to break this vicious cycle by improving the muscle mass and treating sarcopenia, but that is another chapter in itself. Thank you very much for your patience.